In this capture, we're going to take a look at osteoporosis and fracture. So starting with osteoporosis, this is essentially brittle bone disease. So the rate of bone resorption, so those are the osteoclast cells, exceeds the rate of bone formation, the osteoblast cells. And basically, it's fragile bone tissue. The bone is easily broken, leads to fractures. Osteopenia is the precursor to osteoporosis. So this is where you're starting to see some bone demineralization, but it's not quite to the level of osteoporosis yet. Bone mineral density peaks at about ages 18 to 30, and there's a significant decrease in postmenopausal women, and it's postmenopausal due to the loss of estrogen. The estrogen actually stimulates osteoblasts and inhibits osteoclasts, which is why you see such demineralization after that estrogen is gone. Common sites of fracture that we see are the hips, the wrist, and of course the spine. So this all goes back to understanding normal functioning in the body and how calcium levels are balanced to maintain what we need extracellularly for cardiac function and also in the bones. So it looks at starting with parathyroid hormone, okay, and that regulates the serum calcium. So if serum calcium is low, more parathyroid hormone is secreted, and that causes calcium to go from the bone into the blood. So it's demineralizing the bone. Okay, and where the calcium comes out, bone cysts form in its place. Okay. On the flip side, if calcium levels are normal in the blood or a little bit higher in the blood, higher end of normal, the body will be like, okay, I can take some of this extra calcium and put it into the bones. Now, calcitonin is secreted by the thyroid gland. So when serum calcium is high, more calcitonin is secreted, causes deposit of the serum calcium in the bone, and a slowdown in the bone resorption. So these kind of work like a teeter-totter, a seesaw, if you will. Okay? This is why, if you think about these two things, the parathyroid hormone, well, where are the parathyroid glands? They're on the back of the thyroid, okay? And calcitonin is secreted by the thyroid gland. This is why patients who have had thyroid surgery or thyroidectomies or hypothyroidism are at higher risk for osteoporosis. So risk factors and health promotion. Let's kind of talk about risk factors first, and then that kind of leads us into health promotion. Some of it's just genetics, okay? You can try to change, who you are, kind of reinvent yourself. You really can't change your genetics. We know that females are at higher risk. Caucasians and Asians are at higher risk. If there's a family history, you're at higher risk. And also if you have a small frame, okay, a small bone skeletal frame. We know that age, postmenopausal, your risk goes up. Even for men, as they get older, their testosterone levels go down, and that's going to increase their risk. There's also decreased calcitonin as we age. So those things we can't fix, okay, can't fix them. From a nutrition intake, we know low calcium, low vitamin D, or high phosphate intake, those all will interfere with the amount of calcium available in the blood that the body can use. Okay. Physical exercise, we know being sedentary, not really engaging in weight-bearing exercises are going to put somebody at risk, as well as low weight and low body mass index. Lifestyle choices such as intake of caffeine, alcohol, smoking, also lack of exposure to sunlight, okay? Vitamin D, one of our sources is the sun, so we do want to have some sun exposure, but also using appropriate sunscreen to protect our skin. Certain medications are going to put somebody at risk for osteoporosis. Corticosteroids, okay, are probably the number one medication that's highest risk for osteoporosis. But you can also see this with anti-seizure medications. You can also see it with thyroid hormone replacement, things like levothyroxine. And then certainly any comorbidities that interfere with nutrition are going to play a role. So when you look at risk factors and you look on the flip side at health promotion, having a balanced diet with adequate calcium and vitamin D is important, as well as avoiding things that are high in phosphate. Carbonated beverages are high in phosphate, so they are really not recommended. You want to try to minimize those as much as possible. Sometimes, no matter what we do with our diet, there's just not enough calcium and vitamin D. And the reality is that your body can only absorb so much calcium at any given time. So it's not uncommon for older adults to use calcium and vitamin D supplements. It is important, though, to space those away from meals so you're getting your most bang for your buck throughout the day. Daily weight-bearing exercise, such as walking, is extremely important to stimulate the calcium staying in the bones and bone development, as well as weight training. And not weight training, how much can I lift, 400 pounds, but it's the lower weights and the endurance that we're constantly working those muscles, those bones, with that little bit of weight resistance. So with osteoporosis, what you're going to see is reduced height, okay? Back in a previous capture, I talked about how having a person's height at every annual checkup and trending and watching those values was important, because with osteoporosis, we often see vertebral compression fractures, which will eventually result in a reduced height, or essentially they're shrinking, they're getting shorter. So it's important to have serial height measurements and be able to trend and compare those. Acute back pain, especially after lifting or bending. It's worse with activity, relieved by rest. Okay, we see this a lot with vertebral compression fractures. Limited range of motion, spinal deformities. We often see kyphosis in these patients. They tend to kind of hunch forward, lean forward a little bit, and end up dealing with a humpback, that kyphosis. If they have a history of fractures or pain upon palpation over an affected area, there may be an underlying fracture there. So some testing that you'll commonly see, we're going to do the serum test. We're going to look at serum calcium and vitamin D. We'll look at phosphorus. They may look at bone turnover markers, but that's not quite as common as your standard calcium, vitamin D, phosphorus. They may look at serum hematocrit, ESR, alk-phos, and that's mainly to rule out other conditions. So they might just do it with the blood panel right off the bat, so we're not sticking somebody multiple times, but they're going to look at the calcium, vitamin D, and phosphorus first. They may look at x-rays, especially if they suspect a fracture, okay, where they're looking at something in specifically. The DEXA scan is up there, and I have that asterisk because that is the #1 screening test for osteoporosis. Again, it's a screening. We're looking to identify patients that are at risk for it. Okay, and we'll look at that just in depth here in just a minute. We also have the peripheral quantitative ultrasound and the quantitative CT. Those are kind of used farther down the line to see, again, assessing risk factor, but looking to see if there's other things going on, like there actually are some fractures there. And then, of course, MRI. So getting to the DEXA scan. This is, I mentioned before, it is the screening test. It is the gold standard to measuring bone mineral density. Okay, so very, very important for your patient prep-wise. They do not have to be MPO, nothing like that, but they do need to remove metallic objects for testing. Not that it's going to cause them harm, but it's going to interfere with the accuracy of the test. And basically, this test is going to give them a score. We're going to call it a T-score. And it relates the amount of their bone density to a young, healthy adult. Okay? So anything above -1 is considered normal bone density. Okay? -1 to -2.5 is osteopenia, or low bone mass. And anything below -2.5 is considered osteoporosis. Okay? That's below the gender neutral young adult mean. Okay? So that's really important as a screening test to kind of take a look at what their risk is. So nursing care and client teaching for somebody that's at risk, or perhaps somebody that actually has been diagnosed with osteopenia or osteoporosis. Talking to them about increased intake of dietary calcium and vitamin D sources. Again, though, remember, your body can only absorb so much calcium at any given time. So you can have a meal that is chock full of calcium, probably 4 times the amount you need for a day, and maybe only a quarter of that is going to be absorbed. So when you think about increased intake of the dietary calcium, vitamin D, it does need to be spaced out throughout the day. Limiting caffeine, alcohol, and particularly carbonated beverages is very important, because those carbonated beverages have increased phosphatate in them, and that's going to interfere with the absorption of the calcium. You want to make sure they're having adequate protein. Protein provides the building blocks for cellular function, for cellular growth. Those osteoblasts are not going to be able to work properly if they don't have the building blocks to support the production of ATP and energy within the cell. Calcium and vitamin D supplementation. Again, we're not getting enough dietary. We'll use supplementation. Space those away from your main meals to get the most bang for your buck. Weight-bearing exercise, walking 30 to 40 minutes daily, and of course isometric exercise just to strengthen the muscles and improve posture and functioning. Moderate sun exposure using sunscreen. Okay, we don't want to trade one problem for another. And then the other big focus is about safety and reducing the risk of falls. So this is just basic stuff related to, fall risk reduction. Throw rugs, lighting, walkways, making sure they're knowing where they're stepping, proper use and safe use of assistive devices, watching slippery surfaces, and of course, proper shoes, rubber bottom shoes that help with grip. Pharmacological therapy that we'll talk a little bit more about in class since it's part of your prep. Calcium and vitamin D supplements. We have the bisphosphonates, alendronate, calcitonin, estrogen agonists, antagonists. We have parathyroid hormone, your SERMs, your monoclonal antibodies. Again, all of these things are about either promoting bone growth or preventing bone resorption. Okay? So again, we'll talk more about those in class, but just to give you an idea that there is pharmacological therapies related to osteoporosis. Therapeutic procedures, post-compression fracture. This is vertebral compression fracture. Some patients will need a orthotic that goes around their chest to help stabilize their spine. These are custom fit, so they have to be measured, molded for that specific person. And it's all about providing support and decreasing pain. Depending on the situation, we might be looking at joint repair or arthroplasty. In some cases, this is done preventatively for patients with significant osteoporosis. Sometimes it is done post-fracture. They've had a fracture, and now this is part of the surgical treatment post. For compression fractures, we also look at vertebroplasty or kyphoplasty. So this involves injection of bone cement into the vertebral column to try to strengthen things. There may or may not be balloon inflation. So the balloon inflation is the insertion of a tiny catheter with a balloon on it, inflating the balloon to kind of help open the space up between the vertebrae before they put that bone cement in. So they can either do it with or without the bone inflation. Things to keep in mind for caring for patients post-vertebroplasty or kyphoplasty. They are going to be mildly sedated for the procedure. They have to lie in a supine position for 1 to 2 hours following the procedure. Okay. In some cases, they're discharged as quickly as 4 hours post-procedure. Obviously, monitoring the vital signs, the shortness of breath. We're looking for any respiratory compromise there. Doing a neurologic assessment, neurovascular assessment to see what their baseline is post-surgery. Cold therapy to the injection site on the spine. There will be a dressing there. They want to keep that dry. That'll be removed the next day. of course, teaching them, or really a family member, because they're not really going to be able to see their back, but teaching a family member about signs and symptoms of infection, and that they can resume their activities like walking the following day and then gradually increase as tolerated. Ideally, we're all about preventing complications, but unfortunately, osteoporosis is a silent disease, and fracture may be the first sign that there is actually a problem. Okay. Again, we kind of were focusing on the spine and the hips, wrists, and ribs. The spine, we're talking about compression fractures. So you'll see the decreased height, you'll see the kyphosis, you'll see the Dowegger hump, and that Dowegger hump, that can actually lead to impaired ventilation. So it really interferes with their lungs' ability to fully expand. So then you're going to have only partially inflated alveoli. You can get atelectasis, which can turn into pneumonia, and a huge host of problems with that. Then we also have, of course, the hip fractures, the wrist fractures, the rib fractures, that are the three top fractures for older adults with osteoporosis. Again, DEXA screening is important if we can early identify those with osteopenia and osteoporosis. We can incorporate interventions to reduce the risk. The reality is, for women, by about age 80, women who actually have a diagnosis of osteoporosis, they've lost about 50% of their bone tissue in the vertebral column. So compression fractures are just huge. It's a huge problem for that population. So your textbook talks about different types of fractures, and we're going to kind of focus on hip fractures just here in a minute, because those are the ones that are most associated with older adults and also falls. But just some basic stuff. A closed or simple fracture is one that does not break through the skin surface. An open or a compound fracture, now you have disruption of skin integrity. There's an open wound, sometimes there's a bone protruding. These are the gruesome ones they like to show on like Grey's Anatomy and things like that. Okay, but open fractures are pretty serious, because not only do I have a fracture, but I have the break in skin integrity, which is a portal of entry for infection. Complete fracture goes all the way through the bone, dividing it into two distinct parts. Incomplete fracture is only going to go through part of the bone. Simple fracture has one fracture line. If it's comminuted, it's going to have multiple fracture lines, and that's in multiple pieces. Those are a little bit more difficult when it comes to reducing them, getting them back in alignment for bone healing. Okay. So you can kind of take a look in your textbook at the different types of fractures. There is one I want to mention in particular. Let me see here. It's not on here. I'm just going to back up a minute. A green stick fracture, which is also known as like a spiral fracture. It often happens with like a twisting of an extremity, a twisting of a limb. I like to point that one out in particular, because that one is commonly associated with physical abuse, child abuse, elder abuse, because it's like the twisting of an extremity, and it can cause a green stick or a spiral fracture. So just to be aware of that. Here's some additional ones. Depressed fracture, where you can see fragments are driven inward. You can have an avulsion, where things are pulled away by the tendons. And you can see a nice picture of a compression fracture there, where you can see the fracture lines within that vertebrae. So I want to focus a little bit more on hip fractures in particular, because we deal with that a lot with the older adult population. And before we go into that, if I can draw your attention to the picture at the top right screen, that just shows you the anatomy of the hip bone. It's important to kind of know the head and neck area and the extracapsular area, because how these are treated, it's going to depend on which area of the hip has actually fractured. So incidence, we see this a lot in the elderly, particularly in women with osteoporosis, those with frequent falls. Now, here's the thing. We go back to which came first, the chicken or the egg. In many cases, we think about osteoporosis. It causes porous bone, and it can cause a fracture. And that fracture, obviously, once it's fractured, you can't support the weight, the patient's going to fall. We also have cases where the patient was doing okay, they fell, and the trauma caused the fracture. So you can actually have either one. The problem with hip fractures is the mortality rate. Okay, if you look at mortality 1 year post hip fracture, 12 to 32% of those patients will be dead. Okay, this is often, hip fractures are often the beginning of the end, and it often causes a downward spiral for your patient. Avascular necrosis is a common complication. We'll talk about that just a little bit later. Okay. Signs and symptoms. They will have leg shortening. So if you look at the length of the leg, because of the fracture, the side with the fracture, that leg will be shortened. Their legs will often be adducted. You can kind of see how the fracture leg is moving away from the body, and it's externally rotated. Patients will often experience pain in the hip and groin, and they'll also have medial knee pain. Okay. Hip fractures are going to require surgical fixation, surgical stabilization. So, health promotion, as we mentioned before, with osteoporosis, all of these things are going to still apply. Calcium and vitamin D, exposure to sunlight, really trying to identify our osteoporosis patients so we can take preventative action with medications, safety and injury prevention. Your risk factors are there. Risk factors, in addition for fractures, of course, falls, traumatic falls that are just not related to osteoporosis, motor vehicle accidents, traumatic accidents, contact sports, substance abuse, again, just because of the risk of injury related to impaired judgment, physical abuse. It may also be related to diseases such as bone cancer and Paget's disease, and also lactose intolerance as well, because those patients tend to be deficient in calcium. So expected findings, again, we kind of mentioned this a little bit before. Risk factors, if they have a history of trauma, bone disorder, that corticosteroid therapy. And remember, corticosteroid therapy is often used for autoimmune diseases. Inhaled corticosteroid therapy is often used for chronic airway problems, asthma, COPD, emphysema. Okay. And the other one that's kind of newer on the horizon that I want to mention for medications that put people at risk are proton pump inhibitors, are PPIs, such as omeprazole or pantoprazole. Okay. They are all about decreasing secretion of gastric acid, so we use them a lot for GERD. We are seeing higher rates of osteoporosis with that medication and increased risk in fractures when they're used for long periods of time. Your patient with a fracture is going to have pain and reduced movement in the area of the fracture and beyond the fracture. There's typically going to be a deformity. Usually it's going to be a rotation of the extremity. It's going to be shortened. It's definitely going to be asymmetrical. So go back to your basic assessment where you're comparing one side to the other side. Certainly if it's an open fracture, you're going to have a visible bone and an open wound. They may experience crepitus, which is cracking, groaning of the joints, muscle spasms, edema, and ecchymosis. And in some cases, they might experience what we call subcutaneous emphysema. So if you're palpating on the skin where that is, it feels like air bubbles cracking, and it sounds like Rice Krispies. If you put your ear up to Rice Krispies when you pour milk on them. Lab-wise, with the fracture, if we do the CBC, there may be decreased hemoglobin, hematocrit, red blood cells if there's some bleeding and trauma. White count neutrophils are going to be up simply because of the inflammatory process. And your ESR, your erythrocyte sedimentation rate, that's going to be increased because of the inflammation. Although that's not specific to a fracture, ESR is going to be up in any type of inflammatory process. Diagnostics, standard x-rays are going to be your basic first thing that's done. They may do CT MRI to identify location and type of fracture. And again, to kind of confirm, rule out if it's a pathological fracture from a tumor or a mass. If they need to look at soft tissue damage, that's going to be the MRI. Bone scans are often used if we think there are like stress fractures in the feet and the ankles, things that might be very hairline, very slight ones that may not be picked up on a CT MRI. But for the most part, it's going to be standard x-rays, CT, MRI. So initial nursing care with fractures, airway, breathing, circulation. Okay, if they don't have an airway, it doesn't matter if their femur is sticking out, okay, because if they don't have an airway, they're going to die anyway. Okay, so airway, breathing, circulation. Looking at those vital signs, looking at their neurological status and their neurovascular status. Okay, because again, with these fractures, you can have disruption of blood vessels, you can have disruption of nerves, so we worry about what the status is to that limb. You want to splint that limb, no unnecessary movement. You want to splint it so it is staying stationary and maintain alignment of that affected extremity. If you are able to elevate the limb above the heart, that's great. If you're talking a hip fracture and they fell and there could potentially be a spinal injury, obviously we're not doing that. Apply ice as able to kind of help with pain management, but also reduce the swelling. You're going to assess for bleeding. If there is bleeding, we're going to apply pressure as needed. Again, with some of those open fractures, if they nick an artery or even a vein, you can have some pretty significant bleeding. We want to remove clothing and jewelry on the affected extremity. If we can cover the open wounds with a sterile or at least a clean dressing, that's great. If not, you MacGyver it and you use what you have. Okay? Ideally, a sterile dressing is in the perfect world, but if all I have is a clean t-shirt, that's what we're doing. You want to keep the client warm because it's not uncommon for these patients to go into shock. Manage their pain as appropriate, and then you want to inquire about the cause of the injury because that's going to help the providers once they get to the hospital really kind of determine, is this going to be an isolated fracture or is there a potential for other internal injuries, particularly things like motor vehicle accidents, falls, that sort of thing. Ongoing care. They're going to be neurovascular checks hourly for the first 24 hours, and then afterwards every 1 to 4, depending on what is prescribed. We've talked about this before. Pain, sensation, skin temp, skin color, cap refill, peripheral pulses. Comparing the affected extremity to the unaffected extremity. From a nutrition standpoint, we want a high protein, high calcium, high iron diet. We want to supplement them as prescribed. We really want to ensure hydration, okay? Because by increasing the protein and the calcium and the iron, that can put a little bit of strain on the kidney, so we want to make sure they're well hydrated. Meds, we're focusing on pain management, opioid, non-opioid NSAIDs, antibiotics, stool softeners as well, because they're going to have decreased mobility moving around. They've had surgery with the anesthesia. They're going to be on the pain meds. So stool softeners, and I would even say to the next level, laxatives. So the goal is to reduce and immobilize the fracture. So this can be done in a closed fashion or it can be done in an open fashion. So let's start with closed. Basically, we're going to do a pulling force. It's going to be applied manually, and it's all about realigning the displaced bone fragments. Okay, that will correct the deformity. It will get everything back in line to promote healing and circulation and have everything lined up for the body to heal itself with the osteoblasts. Once it's back in line, we're going to immobilize. Casts, splints, immobilizers, traction, external fixation, whatever we need to do to keep that immobilized so the body can heal. Sometimes that cannot be done in a closed fashion, and then we're looking at an open reduction, and then that will be an internal fixation. So you'll sometimes hear that referred to as an ORIF. Please do not call it an ORIF. People will laugh at you. It is an ORIF. So this is where they actually make an incision. They go in, they visualize the fracture, and they are going to reduce it, get it back in line, manually manipulate that, and then fixate with plates, screws, pins, rods, what prosthesis. Sometimes they can't fix it and they actually need to do a whole joint replacement. Okay. After the bone heals, in some cases they may remove the hardware. In other cases, it just stays there forever. Okay. But the whole process is really the same in the sense that we're realigning the bone and we're immobilizing it, we're fixating it into place. So post ORIF, if we're talking about a hip, we want to prevent dislocation. So the same hip precautions we talked about with the hip arthroplasty, not bending over 90 degrees, not bending over to put their shoes and socks on, not crossing their limb past the midline, not internally rotating. That is all things we want to do for a patient with an ORIF. We want to watch skin integrity, not only at the incision site, but also at areas where they would be prone for skin breakdown because their mobility is going to be limited. Neurovascular assessment. I cannot say enough about that. Let's make sure that they have adequate movement, sensation, and circulation to that affected limb. If there is a cast, and the dressing is under the cast, a lot of times they'll have a window cut or a window block in the cast so you're able to see the dressing. Pain management is going to be very important. We've talked about that before. Bowel and bladder elimination. Again, they're going to be at higher risk for constipation just simply because of the surgery, the anesthesia, the post-op opioids, the decreased mobility. Bladder. You need to make sure you're getting them up, putting them on the bed, putting them on the bedside commode, on the toilet, gentlemen helping them stand for urinary elimination. If they're trying to pee on a bedpan, they're likely not going to have complete emptying of that bladder. And you want to monitor for complications, infection, pulmonary embolism, fat embolus. We'll talk a little bit more about that in a minute. TEDs, SCDs, anticoagulants, all about preventing blood clots. We want to support their nutrition. Again, increase their calories, increase protein, increase calcium. Might require supplements. We want to do small, frequent meals because we want to give them as much nutrition as absolutely possible. And if we break their meals up into 6 small ones instead of 3 larger ones, they're going to take in more calories, they're going to take in more nutrients. From a mobility perspective, the first time you get them up, watch them for orthostatic hypotension. It is not uncommon to happen. Usually the first time we get them up and they've been laying in the bed, the first thing I want to do is raise the head of the bed, let them sit in semi-Fowlers for a couple minutes. Then have them sit on the side of the bed with their feet dangling for a couple minutes before you stand them up. You want to turn every 2 hours. Avoid having them lie on the operative side. When you do go to get them out of bed, you want to approach them from the unaffected side. So, complications. These can be pretty serious. One of the earliest complications you might see post-operatively, and really not just with, hip surgeries or fracture surgeries, but any type of surgery, is going to be shock. And basically, there's different types of shock, so we're just going to kind of hit this from a superficial level. But basically, shock means there is not enough oxygen and blood flow getting to the periphery of the body, okay? If your cells do not have oxygen, they do not have glucose that is brought to them by the blood, okay, by circulation, those cells cannot make ATP, which is the cellular energy. The cell cannot function. The cell will eventually die. Okay, so that's really what it's at. And so if you're not getting adequate oxygenation and perfusion to the cells, that can lead to organ failure. Shock progresses very quickly and it is life-threatening. Okay, so it is very important as a nurse that you are watching your patient very closely, because if they're going to have shock or a situation that's going to lead to shock, early detection with prompt response is going to be the key to whether or not they survive. Symptom-wise, they're going to get hypoxic, they'll get progressive tachypnea. Okay, so their SATs will start to fall, their respiratory rate will start to go up because their body is trying to compensate. It's trying to take in more oxygen to get more oxygen into the blood. Their limbs will become cool, pale, eventually dusky and mottled. Hopefully we're catching it before they become dusky and mottled. Diaphoretic, so they will be sweating. Their blood pressure will continue to drop and their heart rate will continue to go up. So again, this is a compensatory mechanism. As the pressure drops because you have inadequate circulation, your heart's going to try to beat faster to try to circulate what's there. The distal pulses will become weak and thready, and you're going to see urine output drop. Okay? If this is happening before they've gone to surgery, maybe it's because the fracture itself might have, nicked an artery, nicked a vein, something's going on there. The treatment's going to involve stabilizing the fracture. If it's happening afterwards, we need to figure out what's causing it. Do they have an internal bleed? What's going on? But the focus is going to be about restoring volume. We're going to use isotonic IV fluids. We're going to use blood products. And it's going to focus on supportive care, promoting oxygenation and promoting perfusion. Okay? And you must deal with the underlying cause. Compartment syndrome. We talked a little bit about this back in a previous capture. Again, with a fracture, you can have the development of compartment syndrome. So just reviewing what you might find. Pain unrelieved by opioids and elevation. Pain with or increased with passive range of motion. That is classic. Paresthesia, numbness and tingling. Pallor, cyanosis, so color changes. Cold extremity, poikilothermia. Okay, and diminished peripheral pulses. If that happens, remove your dressings. If there happen to be a cast involved, we're going to take that off. And worst case scenario, they're looking at a fasciotomy. Okay, again, immediately reportable. Shock signs and symptoms, compartment syndrome, immediately reportable. You need to get that provider there now. Fat embolism. This is another complication that is generally associated with fractures. So what happens is these fat globules from the bone marrow that was inside the bone that was fractured was released into circulation, and these fat globules basically get lodged in the small vessels, in the lungs, the brain, and the kidneys. Most commonly, it happens with hip fracture, and usually it's going to happen within 12 to 72 hours. So we really need to be watching for this. Here's the thing. You need to be able to differentiate a fat embolism from a pulmonary embolism. So is the blockage a fat globule, or is the blockage a clot, a blood clot? Okay. So signs and symptoms. You're going to see decreased mental acuity, some confusion, change in level of consciousness. That's going to be the earliest sign. So when those things happen, don't just assume, well, they're still sleepy from the anesthesia, or, oh, they have a history of dementia too. You have to assess. It goes back to the first step of the nursing process. You have to assess. They're going to start getting short of breath, have some difficulty breathing. The respiratory rate will actually go up. Again, this is your body trying to compensate. The O2 sat will drop. They'll get into respiratory distress. They'll often report a headache and increased heart rate, chest pain, and fever. I have on red on the screen, cutaneous petechiae on the conjunctiva, oral membranes, neck, chest, arms, and abdomen. That is specific to fat emboli. Okay, it is specific to fat emboli. You need to know that because that's something that's going to help you distinguish it pretty quickly. As I move to the next slide here, this picture that's up on there, that is a picture of the petechiae that you see associated with a fat embolism. On a chest x-ray, Not that I would expect you as nurses to be able to look at a chest x-ray and go, oh, that's a fat emboli. No, but it will typically be described as a snowstorm infiltrate. ABGs are going to drop pretty quickly. Treatment is really, really important. We're all about supporting oxygenation and ventilation, okay? So at a minimum, they're going to require supplemental oxygen. In severe cases, they may require intubation and ventilation. They'll be given corticosteroids to treat cerebral edema and inflammation in the lungs. If their pressure drops, we may need to use vasopressors to support their cardiac functioning, to support that perfusion. Fluid replacement, we're going to be dumping fluids into them pretty quick. Pain and anti-anxiety meds. Really, they're going to be on bed rest at this point because any type of exertion, their body is just not going to be able to keep up with the demand. Okay, so for us as nurses, you want to know the signs of fat embolism. You want to know about notifying the provider immediately. What immediate treatment do we want to start? But the real piece we want to look at is prevention. So the best way to prevent a fat embolism, and some of this we have no control over, okay? Once the fracture occurs, immediately immobilizing it. We want to have it fixed early, fixation early, and minimal fracture manipulation. Okay, so that all happens sometimes before they come to us. When we're moving the patient, you want to support that leg, support that hip, support that fracture, and really promoting fluid and electrolyte balance. Other complications include delayed or a non-union healing. So this is a fracture that hasn't healed within 6 months of the injury, or if it heals incorrectly. So it wasn't properly lined up and it healed, so now it's, the bone growth has happened, but it's not lined up and you have a deformity, you have limited functioning. So typically, patients will have persistent discomfort, abnormal movement. Treatment is really going to involve pain management. They may need to actually go back in there, essentially re-break the bone, realign it, and fixate it with an internal surgical procedure. And in some cases, they may need to do bone grafting. Avascular necrosis. I had mentioned this before as a potential complication of dislocations, but you also see it a lot. The risk is there with your hip fractures. So basically what happens is the hip fracture, the hip moves out of place, it fractures, and it actually disrupts blood flow to the fracture site. And when the blood flow is disrupted, you can get necrosis, ischemia, that leads to necrosis at the actual site. So in this case, when you have this that occurs, they actually have to go in surgically, remove the diseased bone area and replace it with a prosthesis and a bone graft. Again, very, very difficult and very long-term recovery for your patient. DVT and PE, this should not be new to you. It is the most common complication of trauma, surgery, and immobility. We're going to prevent it with early ambulation, TEDs, SCDs, anticoagulants, ankle exercises. We want to make sure they are fully hydrated. Want to watch the extremity for redness, warmth, edema, especially increased circumference. Compare one side to the other. That can be a real good way to identify problems. And of course, pain. You want to immediately report any dyspnea and chest pain because that may indicate that the DVT that formed likely in the lower extremity has now dislodged and is up in the lungs. Osteomyelitis is an infection of the bone, typically because there was an open area, portal of entry, bacteria got in, and they set up shop in the bone. You can have osteomyelitis without a fracture. It is not uncommon for diabetic people who have wounds on their foot, those wounds to become infected, and then the infection to move into the bone. So it is not something specific just to fractures. Signs and symptoms include pain. It's usually a constant pulsating pain that's worse with movement, but it's very localized. redness, edema, fever, leukocytosis, so an increased white blood cell count with an increased neutrophil. Treatment is typically long-term antibiotics, long-term IV antibiotics, surgical debridement. If the infection is in the bone, or if it's in a joint prosthesis, an actual joint replacement, an arthroplasty, it can require replacement of the prosthesis, as well as then the wound healing and the dressing changes. So other complications that are a little bit more delayed, but you want to just be aware of, an allergic reaction or a sensitivity reaction to internal fixation devices. Typically, we see this as pain and then decreased function. Basically, the patient develops an allergy or a sensitivity to the metal or whatever the substance was that was used to make the prosthesis. Complex regional pain syndrome. This is severe chronic burning pain, muscle spasms, some paresis, so the numbness and the tingling, and sensory manifestations in the limb. This is more of a chronic issue, so they try to figure out what the cause of the problem is, but basically we're looking at then medications to kind of modify their perception to the pain. And heterotrophic ossification, this is growth of bone in an area that's just supposed to be soft tissue. So this can sometimes happen with joint prostheses or, fracture, ORIF complications, where as the bone is growing back, it grows into an area where it's not supposed to be, like that's supposed to be soft tissue. So that can cause a lot of pain and joint stiffness. Typically, they're going to do x-rays with that, kind of figure out what the cause is. If it becomes extremely painful and the joints are stiff and, your range of motion is significantly decreased, they may go in there and actually do surgery. Best way to prevent this stuff is going to be early mobilization.